SHEM Ministries, souls honoring Elohim's mandate. And now for today's message.
Well, hello. Welcome to SHEM Ministries, souls honoring Elohim's mandate. Thank you to each and every one of you who keep the woman of God, keep me personally in prayer. I thank God and I praise God for each and every one of you. Tonight is our SHEM 2 night. It is a spiritual, healthy, enlightening mandate ministry. And I am Dr. Anna Shaw Devlin. I am a family nurse practitioner. And I love what I do. And in loving what I do, I believe in being the most transparent, acknowledging that I am a human being, that got my little medical hat on tonight. But in being transparent, I wear a lot of hats, and I enjoy wearing all the many hats that God has trusted me to wear. So when God finds favor in you and He trusts you to do something, He's not going to trust you to do something that, number one, He doesn't know you're capable of doing. Number two, that you do not desire to do a good job. That you will not give it 100%. And I am the type of person that I've always been a perfectionist. I have. It is what it is, right? And for people like me, I've had to learn how to wear the hats, give 100%, and find a way to do it in which I personally am refreshed, renewed, rejuvenated, right? I can't give so much of me and not get what I need in return to balance the homeostasis that God created in this world, in mankind, in each human being. He intended for us to participate in maintaining that. How can I teach and tell you something that I myself do not do? So I said all of that to say, during the transition of me figuring things out, right? I will admit that it's been a while since you may have seen me in this atmosphere, right? Seen me in front of the camera. But I've been present. I just have not been 100% exposed in all manners. So, but the last couple of days, I have poured into preparation for you all. And that preparation anyway, it took a little bit longer, but I thank God it was worth me staying up half the night, and sleep in a little extra during today to get it done, because I realized that I now have a part 1 and a part 2 of a message that I totally trust and believe God is something that you really need to know and understand. And the topic that we're talking about is being well informed, okay? And how being well informed helps us to make the right decisions. Many decisions that we make, well, actually, every decision we make has 2 roads. The high road, the low road. You either go to the left or you go to the right. You either move forward or you move back. Opposites, there is an opposite reaction. We learn in physics, for every action, there is an equal opposite reaction, right? The law of physics. Same thing with whatever decision you make in your life. It can be positive or negative. It may start out positive and then turn negative, and then you have to shift and change to make it positive again. But regardless, a decision is a decision, yay or nay. The in-between, the gray area, it kind of exists a little bit temporarily, but you cannot be stagnated and stuck in the gray area. At some point in time, you're going to have to make a decision to either move forward or go backwards or whatever, okay? So that's what we're going to talk about tonight, being well informed and making the right decisions. Now, Father, in the precious name of Jesus, now that I have unveiled the topic of discussion, Lord, that you have given me for your people on tonight, Lord, I need you to help me make it plain. Thank you for the preparation. Thank you for the guidance that you've already given me. And my God, I know that I can't have it all just written out, Lord, because if I do that, then it's all of me and none of you, or less of you. So, yes, we're going to flow in you as we deliver this message. And God, I ask that those that need to hear it, Father, that they open their ears and hear not me, but what you have to say to them. And if the information is not applicable to them, that they will share this so that others may know what they need to know in making the right decision. So bless us, God. Bless us. Those that are listening live tonight and those that will hear the recorded broadcast, that whenever it falls on them to hear, they will receive what thus saith the Lord. In Jesus' precious and holy name we pray. So, now, tonight is my medical hat. And if you look at my hat, you will see a heart and you will see an electrical conduction of the heart. If you ever look at an EKG, you'll see lub-dub, lub-dub, lub-dub. So this is the heartbeat. Glory be to God. The hat that I must wear is my heartbeat for what I have been entrusted to do. Yes. All right. Now let's get started. The first thing that I want to do, because like I said, this is a two-part series. I want to start out by introducing shared decision making. That the decisions that you make, and yes, we're focusing on medical decisions tonight, okay? But the decisions that you make should start out to be shared decisions between you and your healthcare provider, okay? And then I'm going to introduce what a shared decision is. Then we're going to shift and talk about what I think is crucial in this lecture. And it is about advance directives. Because the shared decision is a decision between you and your provider. But what if you can no longer make a decision for yourself? I need you to understand what's going to happen. I need you to understand, I don't care how young you may be, if you get incapacitated, even for a short period of time, somebody has to make a decision for you. Yes, they do. And there are so many hats in that process, and you need to understand them because they're out there, okay? And they vary from place to place, from state to state, and blah, blah, blah. So let's start with shared decision making. And shared decision making, like I said, does not encompass an emergency. Shared decision is not in an emergency situation. And if you don't have this type of relationship with your doctor, because actually, I don't want somebody making decisions for me, because your physician has that right when you can't speak based on what they know about you and can give a doctor's order. We're going to get deeper into that on next week. We're going to start out shared decision, talk about advanced directives, and then we're going to go back into what is involved in medical decision making so that you will understand clearly these things. So before you ever give a person consent, whether it is written consent or implied consent, which can be nodding of the head at some point in time, or it can be based on documented information that your physician put in your medical record that you don't realize is a consent for them to make medical decisions about you as your physician. So, do you know what they're putting in your record? Have you had certain conversations? I mean, real conversations. And not so much as what you've said, but your behavior, your compliance. Did you come back and follow up for your follow-up appointment like you said? I'll give you this prescription. I want you to take this to fix this. And you agree to follow up with me. You don't even realize the decision making you are actually making even without opening up your mouth. Because a prudent clinician, such as myself, you better know that you know that you know. it's being documented appropriately because I got to protect myself. There's ethical and moral obligations and responsibilities that I take as a healthcare provider. This oath to protect, the police, protect and serve, blah blah. Guess what? Anyway, let me not go off on my little tangents, okay? Let's put this up here, okay? This is the little outline that I have for tonight, and we are going to, that's the one for tonight, and hopefully I'm going to leave it up there so I can stay focused, okay? You got to know that you know who you dealing with. All right, but then you're not going to see me because I'm going to put up some slides, and I think I've talked enough that you see I'm alive and well. I am. And by the way, my husband calls these pizza hats. Yeah, he does. All right. Let's start with this. Oop, wrong one. Oh, shoot. Oops. Sorry. I hit my finger did the walking while I was talking, trying to find. Here we go. All right. Let's start out with this slide. And actually, I'm going to eliminate this one just to make it bigger, okay, so you can read with me. And I learned a new skill. I learned how to highlight my slides. I love it. All right. And this information, as I have told you in the past, I get my information from reputable sources like the National Institute of Health. The Cleveland Clinic is where I do go a lot, and I actually left the myclevelandclinic.org up there so you would know. And this was last medically reviewed, and this is I leave this up here, updated February the 6th of this year. Okay, so from the Cleveland Clinic, a reputable source. Shared decision making, and this is in particular to your medical care. One thing that you need to know, and I think where we are not involved in as we need to be in making decisions that pertain to us, is because we think that because we do not have a medical background that we cannot make good choices about our medical care. And I love the way this explains it. It says you do not need a medical background to make good choices about medical care. Shared decision making means you work with your healthcare provider. Now, expert witnesses are needed when you make an appropriate decision. So they become the expert witness regarding the medical issue that you're dealing with. However, guess who is the expert witness regarding you? You are. So if you're sharing a decision, no one knows you no better than you know yourself. Keep that in mind. Do not sit silent and go to your doctor's appointment and let your doctor tell you, well, this is what we have, and this is what and this is what we need to do, and blah, 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 blah. Guess what? They don't have that much time, right? So if you ain't saying nothing, they keep moving forward with, doing their due diligence, what they're responsible for doing. And you basically give up your right in that process of helping to make the right decisions for yourself. So, the topic, being well informed. You have to open your mouth and ask questions. You have to let them know if you don't understand something. But what normally happens, and I'm going to tell you, because I've been in healthcare for 30 some years. I'm going to tell you what happens, because the doctor would come in and he would have a conversation with the patient. He would tell the patient blah, 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 blah. And as soon as that doctor walked out, the patient would look at me and ask me what they were talking about. And what did that mean? So, if you want to know where Ask Anna came from, it came from the role that I have played in the lives of my patients for 30 some years. They would always ask Anna. And guess what? God put it in me that I would be able to explain it to them in a way in which they would understand. And then the patient would say, oh, okay, I understand. Well, that's not what I want. Oh, come on. Then I have to call the doctor back and say, Mr. So-and-so or his wife says, this is not what they want. Okay? All right? I'm just telling you. So this topic is much needed. I think people do better today than they used to because of the internet, because information is out there. Some people will seek, search, and find, and some people won't. But I believe overall, we are more informed people. However, a lot of stuff on social media, a lot of stuff on the internet is just talk. It is not reputable information. It is a person's personal whatever. Okay? But by the time we finish lecture 1 and lecture 2, you should, if you listen carefully and take in what I'm saying, you will have a greater understanding of how to make decisions and the role that you play in making those decisions. Okay? So, your healthcare provider makes choices either for yourself. Okay, wait. I'm sorry. Shared decision making means you work with your healthcare provider to make those choices, either for yourself or for someone you're responsible for. So the parent or, your elderly parents and you're the caregiver, blah, blah, blah. Your provider offers information and guidance. They tell you what they know and they guide you and they support the choices you make along the way. Now, later on, I am going to say to you that everyone did not go to the same medical school. Everyone did not do their residency at the same university or hospital setting, medical center. Everyone did not have the same lived experiences, even as a healthcare provider. So they can only tell you based on their experience, blah, 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 blah. But they do have an obligation to provide you with what the American Association of blah, blah, blah recommends. They do have that obligation to continually do continual medical research and education. And my mama, every time I turn around, you got them CMEs to do. CMEs, continuing medical education, CME. Well, guess what? That's how you stay licensed. You have to agree in order to keep your license that you have participated and and they give you tests. You have to take a test at the end of your CME. Yeah. to show that you remain competent to do what you do, okay? So, shared decision making means you and your healthcare provider work together to make choices about your care. It can help you as a patient or as a loved one, okay? Unlike, and this is what we are going to talk about next week in more detail, informed consent. There is a shared decision and then there's an informed consent. Unlike informed consent, shared decision making is a two-way conversation where you play an active role. Two-way talk, okay? Your provider tells you about your treatment options and give you recommendations. In turn, you tell them what you want from your care. Well, that's not my goal, okay? You may say, my goal is, do you want, it comes down to quality of life. Some people, and you have the right to refuse care, okay? And here's a good example. The doctor says your kidneys have failed and you need dialysis. Okay. Well, what does needing dialysis mean? It means you have to have a dialysis access put in, surgically implanted, placed. It has to heal. It has to mature. Then you have to be stuck. The needles have to go in that access, an arterial line and a venous line that circulate. It actually, the dialysis access bypasses your kidneys and cleans your blood. So you have to have this lifeline put in. Then you have to go to either a dialysis center or you can eventually do home dialysis. And that dialysis treatment, thank God it's better, or the options, there's more options today than it used to be. But for the average person, choosing to do dialysis is 3 times a week, 3 to 4 hours, 3 times a week. You're going to be hooked up to a machine while it circulates your blood and cleans it. There's a potential for infection. There's so much, and I'm not going to get all into that, but that is a decision, shared decision discussion that you have with your doctor and say, no, I want to live where I don't have to go through all of that. I'll just choose not to do dialysis, watch what I eat, do, whatever. Do all the measures that you say I can. And that's where we get into palliative care, right? That you optimize the chronicity of your illness to the point where you choose not to advance toward dialysis, but I do all those other things that I can do without going on dialysis, okay? Now, but that is a shared decision, and you have that right to say, I don't want that. So you have these discussions with your doctor before, way ahead of time. Don't wait until your kidneys are failing and say, oh, no. If you learn that you have a diagnosis of hypertension and diabetes. Diabetes is number 1. Hypertension is number 2. Reasons for renal failure. You don't have kidney disease. But you say to your doctor, who's been taking care of you 20 to 30 years, if my kidneys ever start to decline, I do not desire dialysis. So if you tell them that up front, in the beginning, before you have kidney disease, they will say, I know you told me you don't want kidney disease. And if I see that your kidney function is starting to decline, this is what we need to do to keep your kidneys from declining. But if you never tell them that, that's why so many people don't find out their kidneys have declined or progressively declined until the last minute. I've had too many patients tell me, if my doctor had only told me that my kidneys were declining, I woulda, coulda, shoulda done blah, blah, blah. But they never told me. And you know what I would say to them? They did tell you, but they did not tell you in the language that you could understand. They may walk in there and say your creatinine is going up, your kidneys are declining, and you didn't really catch it, right? Because how many things do you have to talk about in 15 minutes? Okay? All right, let me just keep going. All right. So shared decision making is not like informed consent. You tell them what you want from the beginning. Okay? And what's important to you along the way. Sharing information that way lets you and your provider decide on what's best for you. Okay? Now, let me go to my next slide. All right. Shared decision making is common. And these are some good examples. And then we're going to get into the advanced directive stuff. Okay. Shared decision making is common in many healthcare settings. And it could be something as simple as getting your eyes checked or going to the dentist. That's a shared decision. You could choose to let them pull all them rotten teeth out and not try to get them filled. You could say, oh, I got a cavity. Oh, no. I'm not going to let you start drilling in my mouth and filling that little cavity. And the dentist may say, but wait a minute, it's such a little teeny cavity. And you can save this tooth if we do blah, blah, blah. So it's a conversation back and forth, right? But it is a shared decision because you the one got to pay for it and blah, 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 blah. I know that I had a tooth, a molar, that I had filled so many times over the years, right? So I finally got to the point where I asked the dentist, I said, okay, how many more times are you going to be able to fill this tooth before it fractures and cracks? Because I knew enough from experience that you can have a tooth that fractures, end up needing a root canal and a crown. And I was like, oh no. That happened to me one year right before Christmas and took my Christmas money. And I said, oh, after that, The next time I went to the dentist and they did their examination, I had them assess those teeth and I said, I will not go through a emergent root canal and a crown. And I went on and had all my molars changed out. I sure did. I did. Full disclosure. And if you ever, which hopefully you won't see my molars, but I made a decision that I didn't want porcelain. You know why? Because porcelain can chip. Ain't nobody telling you that porcelain can chip until you ever had a chipped porcelain crown. And then the crown itself gets compromised and you have to end up getting a brand new crown. Now that ain't cheap either. So I said, I want gold, GOLD crowns in my molars. I sure did. But how did I know that? Through experiences. Now, a good clinician, a good dentist, a good whomever you see, honestly, would tell you that stuff. Or you'll get people like me that's willing to tell you the stuff that they ain't got time to tell you. Not that they wouldn't tell you, they just ain't had time. And if you don't ask those questions, you wouldn't know either, okay? And it's not that they're doing you a disservice, you just didn't ask. All right, so examples include things such as deciding whether you want your provider to screen you for certain diseases. Now, every year when you have your annual, your doctor is obligated to ask you, do you need to be screened for STD, sexually transmitted diseases? That's an obligation. Whether they come out and ask you personally, face to face, or they give you this questionnaire to fill out while you're in the waiting room, right? You don't even realize it, but that's a shared decision-making tool. Are you married? Do you have sex with men? If you're a woman, it'll ask you, are you homosexual, or are you homogamous, they ask you all these things, right? Heterosexual, whatever. Those are key screening tools that help them decide. And then they'll read your question, they'll read how you answered, and ask you, do you feel the need, or we can do sexually transmitted disease testing, or do you feel, HIV testing, that kind of thing. All right. Another example is choosing how to manage a chronic condition. Do you want, we could try steroids, we could try whatever, but then you got to know the side effects of steroids. There's so much to know, but this is shared decision making. You have to ask questions. And like I told you, you got to bring something to the table. You got to walk in there knowing a little something, and knowing what to ask. Okay? You need to. Stop just sitting there and my doctor, he'll tell me, you better, not that they would, anyway, never mind. They don't have time. You feel me? Okay. All right. It's not that they don't care about you and this, that, and the other, right? If that were the case, they would not be in medicine. But the demands, how many 40 patients a day that you need to see, 60 patients a day. There are some providers, and we're going to go through the next week on medical decision making and how the scrutiny that doctor is under, or the nurse practitioner or PA, for reimbursement. Okay, that's the monkey wrench in medical decision making. Okay, it is what it is. And then you don't understand when you vote for people that are making healthcare decisions that you don't even realize are affecting you. Okay, we're spending millions and billions and $1 trillion on stuff, and people aren't going to live or have health care coverage to live and enjoy these things. Only the rich and famous are going to be able to afford these things. Okay? Think about it. All right. Selecting a surgery or a treatment, or choosing options for a procedure like the anesthesia type. These are shared decision making. There are people who, I remember, I used to pre-op and get ready for surgery. And I would say we would have a conversation about general anesthesia or other options, spinal anesthesia, blah, blah, blah. And you know what they would say? Oh, just put me to sleep. Not even realizing what general anesthesia was. Being intubated, having a stop breathing while you're having this surgery. You didn't even know why you wake up with a scratchy sore throat sometimes. But now it depends on your airway, because to God be the glory. If a person has a good airway and the person putting you to sleep, you wake up and you don't feel a thing. Okay? All right. But those are shared decision making. Picking a procedure that will have permanent effects, like preventing pregnancy or cancer. Having a hysterectomy, that's a shared decision. You can't have no more children after then. Your treatment for cancer, you say, well, hey, nope, go on, take it all, I don't want it. Or you may say there's a lump and you choose, nope, just take the whole breast because I don't want to deal with it. These are shared decision making. They tell you the risk, the benefit. Now we're getting into informed consent. Wait, let me go back. Shared decision making is just the general conversation, what you want, don't want, that kind of thing. Making decisions that are not life-threatening, but and not picking certain procedure out. You understand? I'm sorry. There's a difference. However, now, in an emergency, everything getting ready to shift. We're leaving shared decision making because in an emergency situation, it all changes. Okay? And now we're getting ready to flip into advanced directives. But in an emergency, and this is what people don't understand, providers focus on number one, and the number one is stabilizing you first. Whatever we have to do to get them stabilized, we're going to do. For example, you living in a area and there's 3 hospitals around you. One hospital is 15 miles away. One hospital is 30 miles away. And the next hospital is 45 miles away. Now, the nicer, bigger hospital may be 45 miles away. And the small, rural hospital may be 15 miles away. In an emergency situation, you have to go to the closest hospital for stabilization. Okay? And they cannot transfer you to another hospital unless medically necessary. For example, you need dialysis, but there's no dialysis at the hospital that was 15 miles from you. So they have to take you, because it's medically necessary, they'll take you to the one that was 45 miles away. And you don't realize these things, okay, until it happens to you. But in an emergency, the first thing is stabilizing you. Unless, and I put this in red, you have an advanced directive like a do not resuscitate. And we're going to talk about that. Okay? There's a difference between an advanced directive, a DNR. Wait a minute. Let me say it this. An advanced directive tells people in advance what directions you want. But the DNR is a type of advanced directive that says, do not resuscitate me. Do not start CPR. Do not pump on my chest. Okay? Do not defibrillate and shock my heart. That is a DNR. It is a type of advance directive, okay? But if you don't have an advance directive or a DNR in place, they have no choice but to do these life-saving emergency stabilization procedures or efforts. But once you're stable, shared decision making can continue with you or a decision maker you've chosen. And that is what I've done a lot of talking. I don't know how much. Y'all know me. Lord, 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 Lord. But it is what it is. And whatever I say, it is because the Lord knows that someone needs to hear it. So let me move on to, let's talk about what is an advance directive. Okay? And then we're going to talk about the different types. But what is an advance directive? It is a legal document. It's legal. You have to get it notarized. It tells your healthcare providers, all of them, and your loved ones. So once you get this advance directive done, signed, and notarized, and guess what? You can print out an advance directive offline. You can fill it out, but it has to be signed in front of a notary. You don't have to wait until you go to a hospital setting to do one, okay? Please know that. But hospitals always on admission ask you, do you have advance directive? And before you're discharged, someone discusses that with you. They should, okay? It's an obligation. So it's a legal document that tells your healthcare providers and your loved ones what type of medical care you want to receive if you can't tell them yourself. The very best time to get this done is when you are feeling the best the best of the best of the best of the best you are. You do not want to make decisions under distress, okay? The document allows you to communicate ahead of time what kinds of procedures or treatments you'd want or wouldn't want. Advance directives also state who you'd want to make sure your requests are carried out. So that advance directive will designate a healthcare proxy, someone to speak in your stead. It should. Your advance directive says if I can't make decisions for myself, the person who knows the most about me that would know what I would want, here they are, okay? And any adult can have an advance directive on file. It's best to complete it when you're still healthy in case you get sick, injured, or aren't able to make decisions for yourself in the future. What if you got hit in the head, car accident, had a traumatic brain injury, and the brain injury, not that you had a stroke now, understand, you could be healthy, you could whatever, but have a traumatic brain injury and not make decisions for yourself. Someone has to make those decisions for you. Making long-term healthcare plans is an important way to make sure you get the medical care you want. Now, I'm going to say this too. Because, a lot of stuff, it comes to me first because, do I have these things? I've talked. I've made my family aware of what I do and don't want, but have I actually physically created one for myself? I'm just going to be honest and say no, because I thought, I just felt that They know me. I tell them everything. But, maybe I need to have one in place. And I believe I probably will go ahead and do that, initiate that. Just because. All right. Now, let's go through the types. Types of advance directives. There's the living will. Now, a living will is a legal document. So the umbrella is an advance directive. Tell people in advance the directions you want. But the different types are this living will, both of them are legal, okay? But this one is more specific. It tells your healthcare providers not just what kind of medical care you want or wouldn't want, but in an emergency situation. An advance directive doesn't necessarily have to say everything the living will says. It also describes what kind of care you would want if you were terminally ill or permanently unconscious. So it goes a little step farther, okay? A living will dictates which medical treatments you want and which you wouldn't. And it also states under which circumstances each of your choices apply. So the living will is a little more detailed, okay? It is like, okay, the only way I want this done is if I'm this, and this. And if you do this, it has to be this, and this. You understand? It's a will. Medical. While you're living. All right. Let's keep going. I hope I got these in order. I'm sorry. Wait a minute. I think so. All right, let's go to this one next. Durable power of attorney for healthcare. This is another type of advance directive. A durable power of attorney for healthcare is a legal document that states your healthcare proxy. Now, this basically is the part that says, so you got your living will, but then you've got your DPA, all right, designating the healthcare proxy. Who specifically, this gives them more, it breaks down more of who does what in particular. And the reason why I say that is because there's the medical power of attorney. So the durable power of attorney encompasses your finances and your medical, right? It's a person that states your healthcare proxy. Your healthcare proxy is the person you've decided that can make healthcare decisions for you in the event you're unable to do so yourself. Someone who should be familiar with your wishes and values. They are also known as your surrogate, agent, or representative. So a lot of times, I'm telling you, state to state, one state may call it this, the other state may say, it's not the easiest, whatever. And I deal with this a lot, and many people use them interchangeably. But the two things, the living will and the DNR, those are the two things that I always ask for first. I don't say, do they have an advance directive? I say, do they have a living will? And do they have a DNR signed? Okay? Because the doctor has to sign the DNR. Okay? We're going to get there. So let me try not to get ahead of myself. But I just need you to know what the durable power of attorney is, a type of advance directive. So you're telling in advance that this is my healthcare proxy. This is the health surrogate or the agent that I have designated to do this, and that. You can name a DPA instead of or in addition to a living will. So it can get complex, you all, okay? But what you need to have is something in place. You got to start somewhere. Give someone authority to make decisions who really knows you. Because I'm going to tell you what happened. Oh, Lord, help me, Jesus. And it says here, another name for a DPA is a medical power of attorney. All right, but let me tell you what can't happen, because this happened to a nursing assistant that I worked with many years ago. And I advise anyone who is legally separated from their spouse, and you have been legally separated for years, and there's no potential or desire for the two of you to reconcile, okay? But if you still have your life insurance together, or you still have this, together, that's another, conversation. But if you are legally married and you've not been together in 10 years, 15 years, you need to divorce. If you have totally separated and gone in separate directions and you have nothing to do with each other, you need to divorce. Because I have seen someone who chose didn't divorce, and their living legal spouse came in and made all the medical decisions for this person. And guess what? The sad thing is, if you have a life insurance policy and you're not divorced, okay, they are the beneficiary if they have not signed their rights away. Yep. And I also learned that even if you have a life insurance policy on an ex-spouse and you're making the payments, if something happens to them, you're divorced, but you still got that policy, they actually can pick and choose their beneficiary. I don't care if you are making the payments. They can choose a beneficiary. And you can't do nothing about it. They could have a will in place that everything, they are their own beneficiary. You understand? They are the beneficiary of that policy. And if they have a living child or mother, parent, whatever, that beneficiary of that policy goes to that person. Okay, all right. Let me keep moving on. Okay. And I'm saying all of this stuff because we don't think about these things until something happens. We don't. All right. Here's I should have cut this top of that off, but the DPA, we already talked about that. The next one was a physician's order for life-sustained treatment. So remember I told you that a doctor's order is a type of advance directive. And they can, you can either have a post or a most done. But let me explain to you what a post is. And the doctor himself can do this post based on your relationship and what they know, and they've been caring for you for X amount of years, and what's in your record, if you don't have anything in place, They can speak up and say this. And if you have not, it's a conversation with the Anyway, it's a lot. It's a lot. But a post is a physician's order. So the doctor can say, I know this person and these are my orders that I want for them or put in place for them, especially in a nursing home situation. They're in a nursing home and they have no family, okay? Or they have no family that's engaged with them. The doctor can sign a post. You feel me? Okay. So the physician order for life-sustaining treatment is a form filled out by your healthcare provider. Usually, you and your provider create the post together after you've been diagnosed with a serious illness. A post doesn't replace your other advance directives, but it provides guidance about your medical care that healthcare providers can act on in the case of an emergency. Okay? Another name for a post is a portable medical order. So you can have a post, a DNR. Usually the DNR is determined after, and here we are. Yep, it's right below. Let me go ahead and let's do the DNR, and then we will call it a night and pick up the tail end of our advanced directives, like the can you have this, can you have that, how does it ever expire, those kind of things that won't take long. We'll pick up with that next week, and then we'll progress forward with additional information about medical decision making. But the DNR, a do not resuscitate order. And most people say they call it the yellow stop sign because it used to have a big, it was printed on yellow paper. I think it still is. And it has a big red stop sign on it. And most nursing homes or whomever, they hand you this DNR paper. Every time a patient is picked up, that's even if at home, so that your loved one lives at home and they have a DNR, you're going to give that DNR to the EMS or EMT, because remember what I told you, they have a legal obligation to treat you in emergency. Your advance directive does not hold weight in regards to stabilizing you in an emergency. So if you do not have a DNR in place and you stop breathing, guess what? You're getting CPR until they get you stabilized and then review your living will or your advance directive. Okay? You feel me? It's a temporary. Unless you have that DNR, you're getting CPR, chest compressions, blah, blah, blah. And so listen, let me read this to you. So the do not resuscitate order is a legal document that states you've opted not to have cardiopulmonary resuscitation attempted if your heart or breathing stops. People who choose to have a DNR are usually terminally ill or have a serious medical condition. In most cases, a healthcare provider writes a DNR after discussing the risk and benefits of CPR with you and your loved ones. Now, Monday night, for example, I had a 96-year-old lady that was very frail and was a full code. And the blood pressure had dropped and oxygen, blah, blah, blah. And I called and I called and I called, trying to get up with the family, to get a DNR so we could do a do not resuscitate, because of the fact that people don't think about what chest compressions would do on a frail, fragile person. I personally have done chest compressions and fractured ribs. In order to adequately do chest compressions, you have to pump hard and fast enough for the recoil of the chest, and you have to press down at least a half an inch that the sternum would go into pumping the heart. It has to compress the heart in order for it to pump. Okay? So it's not a light, it's anyway. And you can fracture ribs, especially if the person is frail, osteoporotic, has osteoporosis, and it happens. Now, the ribs can heal, right? But you just have to know the condition of this person. Were they terminally ill? Had they been sick, or had they had a stroke 5 years ago, haven't talked, have bedridden, haven't been out to bed in years, and total care, and it's a lot, okay? But I need you to understand the importance and the significance of having these things in place. So tonight, we have now completed part 1 of our lecture on being well informed, making the right decisions. We have to assist our loved ones in making the right decisions for us. We have to assist our provider in making the right decisions. Tell them about you, what you do want and don't want. Would you want to be in a vegetative state? No. Yeah, I don't care. What do you want? Do you want to lay there and die slow death on a breathing machine? Are they going to have to declare you brain dead to get you off that ventilator? I'm just telling you, it's something to think about. But I do appreciate you. I appreciate your time with me tonight, and we will continue our discussion on next week, part 2, being well informed, making the right decisions. And yes, I'm going to print out my advance directive, even though I have been very, very vocal, and my children know. My husband knows. My mom and my dad kind of know. But more than likely, they would ask my children and my husband. But I'm just saying. And then there's a step approach as to who gets to make that decision, if there is not one made. And we'll talk about that as well on next week. All right. Well, God bless you. Thank you for hanging out with me on an odd night. And I thank you for your just being with me, supporting me, and knowing that I do get tired sometimes. Yes. And in order for me to help others, I know I have to take care of me. And I get my rest. Yep. And I'm going to keep wearing these hats. The Lord is conditioning me. He's training me for my future. And guess what? It is bright. I see the light, Carol Ann. I see the light. You have to have seen the movie to know what I'm talking about. But So much I see in my future, and I'm going to do everything I can to help you make your future brighter. And we walk this path, this journey together. All right? God bless you. I pray you have a restful night's sleep. To God be the glory. Love, 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 love you.